The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, welcome. This is the next episode of TMD Demystified. My name is Tony Urbanek. I'm pleased to have you here, and I hope what I have to say is meaningful and will help you in the understanding of the science and technology of temporomandibular joint disorder. Some of you, most of you, I understand, are dentists in the dental profession, but there is an increasing number of patients who watch these episodes, so I especially welcome you. Although sometimes I may use words that are beyond your comprehension, and I don't intentionally mean to do that. I try to keep it to the point where you can understand the nature of what I'm trying to say and the concepts I try to get across. But if I don't do that consistently, I must apologize first, because having misunderstood words kind of ruins the whole subject. But today, the topic for today, I think, is a very timely topic on this issue of TMD, temporomandibular joint disorder, which affects the temporomandibular joint, TMJ. The title and topic for today is why we don't need the specialty of oral facial pain. Since 2022, at the discretion of the American Dental Association, there has been a new specialty designated by the American Dental Association called oralfacial pain, OFP, as a specialty. Now, it is my contention and has been my contention all along for many, many years, certainly since I started doing TMD Demystified in this podcast, that making more out of TMD diagnosis and treatment than is necessary is inappropriate. And it is my contention that having a specialty, orofacial pain, for the treatment of TMD is overkill. It is excess. Exactly why and how this came to be with the American Dental Association, I don't fully know. And frankly, because I don't have all the facts, don't want to comment on it. But it is fact that the American Dental Association, in their wisdom, has decided that orofacial pain should be a specialty in dentistry. Well, that remains to be seen. And it is my intention today to discuss this somewhat fully and give a point of view on it that makes the case. There has been for years a group of doctors that I call gurus, G-U-R-U, gurus, who use smoke and mirrors and voodoo kinds of things to treat TMD symptoms. And that is a fact, and you can fact check that fact. And it goes all over the board. And for the most part, none of them are successful in the long term. Now, admittedly, I have to say that I, with 50 years experience as an oral and maxillofacial surgeon, with a dental degree, with a medical degree, with degrees in cell biology and anatomy, and experience doing research with the National Institute of Health, National Institute of Dental and craniofacial research, I have a broad background upon which I base my knowledge and upon which I speak. So I don't bring this stuff out of thin air to your attention. But today's topic is the fact that we don't need a specialty in orofacial pain. And I want to back that up with some facts and some information, and then you can draw your own conclusion. I certainly have made mine. But what I did is I actually presented these questions to artificial intelligence. As you all know, you can Google AI in different places. I just use Google AI, but I'm also a member of CPT Chat AI. But in this case, I just Googled AI and asked a few questions pertinent to, do we need the specialty of orofacial pain? And for a limited discussion on why or why not. So I'm going to go through what I received from artificial intelligence, which frankly is amazing. I have to admit, I questioned it at the beginning, but it is quite amazing as to the accuracy of the information that it divulges, and it has access to obviously a huge amount of information on any particular topic. And I'd encourage anybody out there to begin using it. You will be surprised as to the accuracy and the volume of information that will be given to you. But first, I asked a couple questions. I asked in the United States, what are the certification organizations that certify the specialists in orofacial pain? Because I know that there are actually two, or at least two organizations, competing organizations that compete to certify a specialist in orofacial pain. And the answer came back as the American Board of Oralfacial Pain, ABOP. This is the officially recognized national certifying board for the orofacial pain dental specialty. Since 2022, it has been recognized by the National Commission on Recognition of Dental Specialties and Certifying Boards, a body by the American Dental Association. It is considered the standard for credentialing specialists who have completed accredited residency programs. And then there is the American Board of Dental Specialties, the ABDS. This organization was formed as an alternative to the ADA recognized system. It provides a platform for various dental boards, including those related to orofacial pain and oral medicine that may not have held ADA recognition at the time of the ABDS's founding. The ABDS serves as a private independent credentialing body that challenges the ADA's sole authority over specialty recognition. Admittedly, I don't want to plagiarize. That was read directly off of the AI communication to me. So there are two separate boards who are competing to credential doctors who have this specialty. For example, I'm an oral and maxillofacial surgeon, and I am credentialed and boarded in oral and maxillofacial surgery by the Board of Oral and Maxillofacial Surgery, the American Board of Oral and Maxillofacial Surgery. In this case, we have two boards competing, which is quite unusual. All right, so it goes on. While the ABOP is the only recognized board by the ADA for this specialty, the ABDS continues to represent the specialty for recognition for the broader dental community. Now, I also ask AI about the creation of oral facial pain, and is it really necessary? And this is AI's point of view on it, not mine. And again, not to plagiarize, I'm going to read, what I'm going to do is I'm going to read the response, and then as I read the response, I will put my opinion, guarded opinion, or maybe overt opinion into it. And I hope you'll be able to tell a difference. I'm not going to belabor the point, but I think it's very, very interesting. All right. So it comes back as the complexity debate. There's a critical view. The creation of the orofacial pain OFP specialty is indeed a point of contention within the dental community. Critics and supporters generally view the complexity of the field from two very different angles. The complexity debate. The critical view is you aren't alone in your skepticism. Some practitioners argue that TMD and related symptoms are often overcomplicated by the specialist. This perspective suggests that most TMD cases can be managed with conservative common sense treatments by general dentists, and that turning it into a formal specialty creates unnecessary barriers, increases costs, and pathologizes minor musculoskeletal issues. And there are many other in my point of view, but I totally agree with the AI's point of view on this, the criticism of this, and many others. I contend that it has been created by a specialty to protect the gurus and voodoo doctors out there who've been doing nonsense for years. But politically, they were able to convince the ADA that, and specifically the ADA National Commission on Recognition of Dental Specialties and Certifying Boards, that it has to be a specialty to get good treatment. Now, to give the other point of view, the specialist point of view, and I have a lot to say about this. The specialist point of view, proponents argue the complexity isn't manufactured, but inherent. Well, there's the biggest problem, because the proponents of a specialty make it complex because they think it is complex. They treat symptoms, which are absolutely, I agree, very disparate. We have many disparate symptoms of TMD, and the list is somewhat growing. And as I investigate, the list of the disparate symptoms are growing. But the well-known, well-established symptoms of TMD, temporomandibular joint disorder, are frequent or recurring headaches, earaches, jaw pain, neck pain, ringing in the ears, tinnitus, subjective hearing loss, that feeling of fullness in the ears, you can't clear your ear, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. And that isn't the complete list, but those are the primary, totally agreed upon list of the disparate symptoms of TMD. But if you take each of those symptoms as a separate disease, you're going to complicate things, because it is my contention, which is proven, and actually we're not going to go into today, but supported by AI, that it is a disease which has a common denominator, which is generated by chronic inflammation from within the temporomandibular joint that creates each and every one of those symptoms. So what we have here is a, quote, new specialty condoned by the ADA that is making it extremely complicated. Number one, because they're all taught in dental school that this joint is complicated and it is unique and different than any other joint in the body, which is definitely not true. That was the first big mistake in dentistry, taught in dental schools, promoted by the, quote, specialist in oralfacial pain, because it supports their contention that this is very complicated, which it's not. They claim that TMD is often a catch-all term for disparate symptoms ranging from neuropathic pain and sleep apnea and systemic odontogenic, meaning from the teeth, not caused by the teeth. This is getting into really nonsensical sort of stuff because it is created by chronic inflammation in the joint that uses these systems. It uses neuropathic pathways. It uses neuropathic pathways, has nothing to do with sleep apnea, and admittedly is constantly confused by the patients who say, I have tooth pain. I feel like I have a toothache, but that does not make it some kind of special disease. It is the fact that when the muscles get a stimulus to contract and pull on the bone, a lot of times those muscles are attached right next to the bone that surround the teeth, and it can feel like a toothache. But if you start out from the knowledge that the orthopedic surgeons know about joint splinting and that chronic inflammation in any joint, including the temporomandibular joint, can create contraction of the muscles that move that joint, those muscles will pull on the bone in various places at various times and vary all over the board and cause pain where those muscles are attached. And as the pain moves around, the patient feels that they have various and unusual symptoms. And then it goes into the neck. The neck gets a signal to tighten up, and then the upper back and shoulder girdle gets a signal to tighten up, and you have upper back and shoulder pain, arm, hand, finger tingling, and numbness. But again, without belaboring this too long, specialists are trained to recognize when a toothache is actually a migraine headache, trigeminal neuralgia, or a cardiac event. And it is true when the muscles up here get the signal to tighten up. I have had my own patients who actually reported they went to the emergency department because they thought they were having a heart attack because these muscles up in this part of the upper shoulder girdle tightened up to the fact that it hurt so bad they thought they were having a heart attack, when actually the muscle tension, contraction was generated by chronic inflammation in the temporomandibular joint, signaling all of the muscles of first the face, then the neck, then the upper shoulder girdle to tighten up to hold this joint still in hopes that it would heal. That is the phenomenon. That is the pathophysiologic system that makes all the pain, which is unrecognized, I think intentionally, because the orthopedic surgeons know about it. I've been talking about this for years now. But they seem to think that you have to be really important to distinguish between migraines. And as I've said many times, migraine actually is a catch-all phrase. Medical system, the medical researchers, the medical doctors, of which I am one, have no idea what causes migraine headaches. There's lots of theories. You can read an awful lot of papers giving theories about what causes migraine headaches, but nobody claims they know for sure. That is a fact. Check it. Fact check. And then trigeminal neuralgia, which is apparently a proponent that you have to be a specialist to distinguish trigeminal neuralgia from other kinds of facial pain. Trigeminal neuralgia is actually a catch-all phrase. Trigeminal neuralgia just means pain associated with the trigeminal nerve, which has three parts: upper part, middle part, and lower part. Trigeminal neuralgia. It's a catch-all phrase, and when nobody else knows what to call the pain in and around the head and the face, they call it trigeminal neuralgia. And you don't need to distinguish it from anything because it's a catch-all phrase that's meaningless other than how I defined it. And that's how it's defined. Fact check it. Trigeminal neuralgia is pain of the trigeminal nerve. It's meaningless, other than it's pain of the trigeminal nerve area. We already talked about cardiac event. So you do not need to be a specialist to distinguish any of these things when you understand the real pathophysiology of TMD, which originates of inflammation in the temporomandibular joint, creating contraction of multiple muscles, not only of the face and jaws, but then into the neck and then into the upper shoulder girdle, creating all these disparate symptoms, which if you just treat symptoms, at very best, no matter what kind of treatment you use, is only going to be temporary and sometimes damaging and sometimes very dangerous. So I'll continue. The standardization of care. That's the hope of the specialist, standardization of care. Before the specialty existed, TMD treatment was often called the Wild West of dentistry, and widely varying and sometimes conflicting methods were used. Well, that's what I just said, and I totally agree with that statement. It has been for the better part of my entire career, 50 years, and beyond that, before that, for a couple decades before that, I would say for 70 years, TMD, the treatment of TMD, has been the Wild West of dentistry. The American Board of Oralfacial Pain aims to enforce evidence-based conservative standards to prevent patients from receiving aggressive, irreversible treatments. So they want to enforce their standard of treatment, which basically is treatment of symptoms without recognition of where the cause is. And that is where my big conflict is on this. The third try to support the specialist point of view is insurance and referrals. Official recognition makes it easier for patients to get insurance reimbursement for chronic pain treatment that were previously rejected as experimental or not dental. Well, we know the insurance company is not your friend, and I can tell you from multiple years and specific references and resources that I have and looked into, that, first of all, dental insurance doesn't want anything to do if it's labeled TMD, because they know, they have experience for decades and consider it the Wild West of dentistry. And the medical insurance don't want anything to do and will not cover in any way, shape, or form anything having to do with TMD, because the medical insurance says TMD is dental. So the poor patient, whether he have dental insurance, medical insurance, or both, have limited to no coverage at all on this issue. And just trying to treat symptoms, all of the insurance companies know that it's been the Wild West. And the fourth, and most important, I believe, support for the opposite point of view, the support for the opposite point of view for mine, is the biopsychosocial model. And that is the model that the TMD specialists, the orofacial pain specialists, use. It's called the biopsychosocial model. Unlike traditional dentistry, which focuses on mechanical fixes, and the specialty uses a model that accounts for how stress, sleep, and the nervous system impact physical pain, which requires diagnostic time that is more timely than regular dental appointments. This biopsychosocial model brings psychiatrists into it, brings psychologists into it. They claim that, as we do know, that bruxism, which is only one cause of damage to the temporomandibular joint, there are two other causes. Bruxism, or clenching and grinding, is certainly one of them, and probably the primary cause of the three, admittedly. but we do not have an answer for bruxism. We don't understand the mechanism of clenching and grinding under stress. I think everyone on the planet has experienced it. It has been documented in the biblical literatures, clenching and grinding of the teeth. It has been going on for a long time. Half the population clenches or grinds, but to simply try to treat patients by getting them to decrease their stress or to somehow keep them from clenching or grinding when you don't know exactly how the mechanism operates is smoke and mirrors. It's voodoo. But that actually is, according to AI, please check your facts, it is the standard of which the orofacial pain specialists operate to decrease stress, to improve your sleep. I think everyone would maybe like to improve their sleep, and then treat the nervous system. And there's a lot of people out there and a lot of drugs out there that attempt to treat the nervous system with tremendous amount of side effects, unintended consequences, some of them severe, some of them catastrophic. I've written blogs on that, and I've had other podcasts on that issue of the use of drugs of various kinds and the complication of drugs for treating TMD. So we have a contentious issue, whether there needs to be a specialist and what is the intention of the specialist versus a understanding of the problem and the actual true pathophysiology of this problem that we now call TMD, that for decades was just called TMJ, the name of the joint. And again, what I discovered was my discovery, but I just connected the dots. It really wasn't hard to do when you took an objective look at it and removed all the bias involved with this problem. And I admittedly had bias as an oral and maxillofacial surgeon that surgery would eventually be the answer. And when I decided 15 years ago, after doing 2,000 temporomandibular joint cases, independent cases, surgical cases on the temporomandibular joint, some of them unilateral, some of them bilateral, half of them were open joint surgeries where I opened the joint from the outside with an incision in front of the ear, and half of them through an arthroscope into the joint. But after 35 years of doing those 2,000 cases, I decided, because a third of my patients would be back within a year or two with the same symptoms, I decided I was not going to continue doing any more temporomandibular joint surgery because I could not, in my own way, specify and look in a patient's eyes and say, I'm going to fix you. That did not sit well with me. And I decided if I can't tell a patient exactly what they can expect after my surgery, and I could with other surgeries, with facial reconstructive surgeries, microneural surgery, cleft palate surgery, orthognathic surgery, even the simpler stuff, you take out a set of wisdom teeth, you know exactly when you're finished what the patient can expect over the long period of time. And I could not do that doing temporomandibular joint surgery. And I decided not to do any more TMJ surgery because of my broad background. I decided I was going to sit down and see if I could do the research. I am a researcher with qualifications and statistics and degrees. And I was going to see if I could figure it out. And it did. And it turned out to be pretty simple, that any general dentist can do. Any oral maxillofacial surgeon can do within his specialty. In fact, for all oral surgeons out there, you well know that you're not supposed to, standard of care, operate on a temporomandibular joint without attempting more conservative treatment before you attempt to do surgery. And conservative treatment definitely is what came from my research, to use a small orthotic, a little device that went in between the teeth, that did nothing more than rest the joint like a set of crutches rest the knees, or a sling rest the elbow if you have tennis elbow. And the orthopedic surgeons knew all about this for the past 50 years. And the general dentist and the dental schools never read the literature. And if the orthopedic surgeons had kept control of this joint instead of giving it to the dentist to figure out, which they didn't, this problem would have been solved 50 years ago. But the orthopedic surgeons didn't want anything to do with it because the jaw was connected to teeth, so it must be a dental problem. And that's how it ended up in the lap of the dentists and the dental schools and the dental profession, that ended up in the Wild West of treating the problem because everybody thought it was difficult, and because now it's specialized with its own specialty, in quotes, now they're validated to make it complicated. It's not complicated. If you unload the joint according to appropriate protocol, 24/7 for 2 months, nighttime only the rest of your life, you can eat with it, you can drink with it in your mouth, you can breathe with it in your mouth, you can talk with it in your mouth, you just can't chew with it in your mouth, you got to take it out when you eat. And very importantly, for the first 2 months, you have to do the 24/7 part. Very appropriate and very important. So that is my reasoning why we don't need the specialty of orofacial pain. And apparently, I have good support from artificial intelligence on this. But it's still debatable. And if you would like to debate me, if you are a doctor who'd like to debate me, you're welcome. And I'm available. You can reach me at tony@tmjservices.net. If you are a doctor who'd like to learn how to do this, because this is a patented device and service, you're welcome. We want you, because we can't see all these people out of Middle Tennessee. I had 2 people fly in from Nevada yesterday to see me. I need a doctor in Nevada. We now have doctors in 18 states and growing. So if you are a dentist who would like to do this for your patients, you have to take a little course. You have to know a little bit about the nuances of using this device, how, why, and how it interfaces with patients. You can go to our website, www.urbanektmj.com. Urbanek, URBANEK, tmj.com. It's all there, and you can also contact me if you'd like. So with that said, I hope I've made the point. I could go on, I could drone on longer, but I have much more to say about the specialties of orofacial pain and the way that they have come about getting this made a specialty, and the specialists trying to make it complicated. I mean, I have seen some of these workups that these orofacial pain specialists do. I mean, I have received written documents that are half-inch thick of paper of workup comments and materials that are done that sometimes take 2 or 3 hours by these orofacial pain specialists trying to make it complicated. And why are they doing this? I can tell you for sure. They're doing it so they can make it look complicated so they can apply for medical insurance coverage and try to make it a medical problem, medical sounding problem. Well, it's a problem, and it does cross between medicine and dentistry for sure, but it is a problem of inflammation and the effect of inflammation within the temporomandibular joint. With that said, I look forward to the next time that we discuss temporomandibular joint problems on this podcast entitled TMD Demystified. I am Tony Urbanek and appreciate you being here. Thank you for being here, and I look forward to the next time that you listen to what I have to say.